Hello, this is the integrated management of age associated disease, and during this talk, we will cover the broad recommendations made to the HSE management team around the processes and the perceived best practice outlines for managing age associated diseases across the country. I propose to cover the topic under the following headings: the person, the population, the system or systems that we have in place at the present time to deal with age-associated problems as they relate to the individual and the population, the change and changes that we think ought to be made, the perceived dividend from affecting these changes, and then the take-home message. This is a poor pixelated photograph of Peg taken around 1936, at the time that the Irish Folklore Commission was gathering stories on her life, and she's photographed here with Robert Flowers at a time when she would have been, I guess, in her late 50s, early 60s, and she's exhibiting all of the quintessential aging features that we would typically associate it with progressing old age. She's stooped. She's well, I guess her clothing doesn't help matters either, but she not only looks old, she's thinking old. Shan van shan misha anish a will cos lay san uig is an cos ella brok. Here I am, an old woman now, with one leg in the grave and the other on the edge. Fast forward 70 odd years to an article that just caught my attention in the Sunday Independent, under the title "Middle Age Catches Up on Cher." And you can see the appearance is different, and of course the attitude is different. So a lot has happened in terms of our perception of aging in that 70 odd year period. There have been some dramatic changes in that time. In this country, 20 years has been added to life expectancy from birth over the 20th century. So for every 5 years that went by, on average, 1 year was added to life expectancy. Largely due to improvements in perinatal health. And a baby boy born in this country today can expect to live to 74 years. A baby girl born today lives to 81 years. Life expectancy will have risen to 85 years for men and nearly 93 years for women by 2025. By 2025, and in fact, it's projected that by 2035 that there will be 1 million people over the age of 65 in this country. There are many theories that exist to explain the aging theory, and why one individual may age more rapidly than another. Many of these are not hugely helpful in a clinical setting, but the one that I think is of greatest value, and it's not even a theory, it's just a notion, is this notion of homeostatic reserve. It's potentially nicely illustrated on this diagram here. We can consider these as a series of graduated cylinders into which we have fluid, or you can consider it as a petrol tank with petrol, and the level indicates the amount of fuel in our cylinder, or water in our cylinder, or fuel in our petrol tank. In this instance, we have an individual who's got good reserve, largely as a result perhaps of having lived a healthy childhood with a mother that's had good maternal health. And reserve, for example, it could be bone mineral density, it could be muscle strength, it could be cognitive reserve. It will inevitably, of course, decline with the passage of time. But this can be managed by being cognizant of the risk factors for osteoporosis, for cognitive ill health, vascular ill health. But inevitably, as reserve declines, one gets closer to manifesting overt disease, and getting closer to the red zone down here. And when that happens, fairly innocuous physiological stressors can result in what look like major clinical events. So, a common cold, for example, can rapidly result in an episode of delirium, depending on how close you are to the red zone here. In the second individual, they've got good reserve, but uncontrolled loss. This is somebody who's perhaps genetically quite robust, but whose lifestyle is such that they hit trouble prematurely. In the third case, we have somebody with poor reserve, but with managed loss. Um, Genetically, things stacked against, but good lifestyle measures that mean that he or she can avoid ill health prematurely. In the fourth example, poor reserve and uncontrolled loss. In the final example, which is one that I guess most modern geriatricians are interested in, which is this notion that in fact you can now look into the petrol tank at some stage. You can stop, have a look, see what reserve is like, do something about it, and reverse the process. Bone density is a very good example of this, where you can actually now build bone if you know that your skeletal reserves are low. So, there is a genuine interest nowadays in longevity. There's clearly an interest in quality of life, but more and more people are interested in leading long and healthy lives into advanced old age. There are many examples in biological systems of species that live into advanced old age. This is Janik Kalma here, who lived, I think, to be about 121 or 23. Yellow-eyed rockfish, the Galapagos tortoise, and I think this is the prickleback spine thing that lives up in, or grows in North America, can live for thousands of years. So much for the individual. What about the population? This is meant to represent life from start to finish. The one inevitability about life, of course, is that it's going to end. This point here, the grey bar, represents the time spent in active employment, say up to the age of 65 in most cases, and the yellow bar, the period spent in the post-retirement phase. The one certainty is that it is difficult to die without antecedent morbidity, and it has been variously estimated that the entire morbidity encountered by an individual in their life, that 60 to 70% of this is encountered in the last 6 months before an individual dies. So this, I guess, is the sort of self-evident reason why hospitals tend to be full of older people, because morbidity largely resides in the latter stages of life. We've said already that we're scheduled to have an increase in life expectancy over the next 20-25 years, and of course that's very welcome. People would worry a little bit, however, if this increase in longevity was associated with an increase in morbidity. I think most of us would be quite happy to accept the same level of morbidity, but with an increase in life expectancy. I think the nightmare scenario, of course, would be that the additional years that we might live would be entirely morbidity laden. Most of us, I guess, would put up with a little bit of this and a little bit of that. In fact, data coming largely from North America suggests that there will be a contraction in the amount of morbidity that any individual will encounter in life. This is the so-called live long, die fast view of morbidity with increasing longevity. This, I guess, would be pretty good for healthcare providers, because while we might have more people around, it's likely that we might have roughly the same amount of morbidity to deal with. No matter how you look at this, however, it's a bad deal for pension providers, because we'll have more, hopefully, healthier individuals living. Local data from our own hospital in Limerick suggests that this may not actually pan out in precisely that manner. I've plotted here bed day utilisation for the regional hospital in Limerick in medicine in 1998 and then in 2007. And assuming that you have efficient systems for managing patients in hospital, bed day utilisation is a reasonable measure of activity, and it can be seen clearly that between 1998 and 2007, bed day utilisation rose from just under 50,000 to just under 70,000, and the majority of this increase occurred in patients over the age of 75. So this doesn't quite fit with the live long, die fast view of morbidity and longevity. The morbidities are catered for under the following headings: neurovascular disease, neurodegenerative disease, cardiovascular, osteodegenerative, osteoporosis, falls, renal, and with a lot of surgical geriatric problems and patients needing more and more rehabilitation. And these are hype data. You can see in the grey bars here represent increased bed day utilisation by age. One of the societal difficulties here is that from a purely economic and social support point of view, there would be fewer people to bear the load. Here we have the ratios of workers per retiree for some major Western countries, or developed countries I should say, comparing 1990 figures with projected figures for 2020, and it can be seen in Ireland that the number of workers per retiree in 2020 is projected to be 1.5. So 1.5 people at work for every one person who's retired. Now, it's interesting to look at the variance and the differences that occur in relation to activity in hospitals around the country, because there are quite marked differences. Here we've plotted all of the acute hospitals in the country, and these grey bars represent the number of inpatients in hospitals, admitted to these hospitals in 2004. Now I think the graph has gone off the bottom here, but I can tell you that this here for Limerick represents 33,000 admissions. It'll give you an indication roughly of what these what the bars represent in other hospitals. If we add to this day case activity, we wind up with this relationship, with St James's having the largest amount of activity, but with the regional hospital in Limerick having the largest inpatient activity during that period. This is an activity plot, and if you look at a resource plot, if activity is to be matched to resource, then a resource plot should follow the same shape. However, it doesn't. You can see it starts to distort fairly early on. So there's clear evidence that some hospitals are getting more resource for a given level of activity than others, because here we've plotted bed days in purple and consultant numbers in grey. What kind of systems have we got in place to deal with the aging issues as they currently exist? Well, broadly speaking, patients present to the health system at various stages in their life. Clearly, in the first instance, if you take this young guy, he's out there doing his thing. He very unlikely, actually, as an individual, to need the health system at any stage in youth to any degree. But if he does, he's likely to come into the acute hospital setting and leave as quickly as he comes, and probably not make a further appearance. In midlife, it's slightly different. Most people never come near the health services. But if they do, let's say with an acute episode of gout, other things are often identified. Early hypertension, hyperlipidemia. But again, when the individual leaves, they leave. They may need some closer follow up in primary care, but tend not to impact to a great degree on the workings of acute hospitals. In the third case here, this type of individual would be a major user of health services, both in primary care, back into the community, occasional admissions to hospital care, in and out, getting to the point maybe in later life where it's difficult to effect a discharge in the acute hospital without some rehabilitation input. Back, further admissions, ultimately perhaps needing either community or residential continuing care. So the bulk of the activity and bulk of resource going into looking after age-associated problems. This is the care continuum that individuals are confronted with if they need healthcare provision. Oftentimes it looks fairly daunting, and these bits and pieces of the system often don't look as well connected as they do on this cartoon. So it can be fairly daunting. The whole thing isn't helped by the traditional administrative divvy up with one bit of the organisational system looking after acute hospitals and another looking after special hospitals and continuing care. The expert advisory group, which was convened by Professor Drum to look at how best to provide services for older people, started from an entirely patient orientated perspective, looked at the care continuum and said, right, these are the key areas that need intervention. There needs to be a prevention or a primary prevention policy, a system that allows for the active management of aging in the community, and populations need to understand how they can do this. Secondly, if you need acute hospital care, then the only portal available to you ought not to be the emergency department. So it supported and recommended the development of medical assessment units as first suggested by the Corla subcommittee on medical assessment units. Secondly, it suggested that there was a requirement for clinical diagnostic units targeted solely at age-associated disease. Units that could deal with falls, fractures, syncope, osteoporosis, cognitive issues, and that these should be available in acute hospitals throughout the country. Fourthly, that there should be a structured and systematic approach to the provision of rehabilitation care across the country for all ages, recognising that older people are the predominant users of rehabilitation facilities. Fifthly, that in the event that full rehabilitation potential has been reached and therapeutic potential maximised, then access to residential continuing care ought to be highly structured and have a uniform approach across the country, so that there isn't one system applying in Galway and a second one in North Dublin or anywhere else. In addition, facilitating all of this, it was recommended that there would be an easy-to-use computerized system that would facilitate the management of age-associated disease, and the expert advisory group developed the Unified Needs Assessment program that can be used in any number of ways, as a desktop version or as a multi-hospital system run over a network and a server-based central database. And finally, a recommendation that given that ageing is such an important issue in the provision and efficient provision of health care throughout the country, a recommendation for the development and establishment of a National Institute on Aging Studies, largely and probably incorporating all of the existing academic centres with an interest in ageing. The body of work was divided into two parcels of 7 initiatives. So-called 7-1, which are those that I've mentioned already, and 7-2, which were initiatives that were already in the pipeline and just needed to be primed or pushed over the line. Quickly, in relation to the successful aging code, the successful aging means different things to different people. There is a healthcare perspective on successful aging. There is a societal, personal view on what successful aging means. The concentration here was largely on the medical side of things, and predicated on the view that it is possible to actively manage aging. The idea here is that there is predictable changes occur in biological parameters with advancing age, certainly in population terms, and the idea is that individuals should be able to reference their own biological position against population means for age in the same way as we would do on a day-to-day basis, for example, looking at bone mineral density. Here we've plotted systolic blood pressure for women with advancing age. It is very likely, just very possible, to get a 24-hour blood pressure monitor for a woman and look at where her pressure resides relative to the population mean, and to describe her blood pressure in those terms. In other words, if somebody has a blood pressure at this level here, despite the fact that they're only aged 50, it is reasonable to say that they have the blood pressure of somebody who's aged 70, and this can provide a powerful impetus for change, either through lifestyle measures or appropriate pharmacological intervention for the patient. The same could be true of muscle strength, which will decline with advancing age. Lung function in man. There are many such examples. In relation to the medical assessment units, a subgroup of Corlin and Nussbaum in 2004 looked at the various models of medical assessment units as they existed around the country, the assessment process, the admission process to hospital, and recommended the establishment of such acute medical units. It did not make a specific recommendation in relation to how these units should be run, but simply outlined the principles for success and recommended that they be established in acute hospitals. They said that there were only one part of a whole system approach to improving assessment, admission and discharge processes. The expert advisory group endorsed and support the principles of the Corla subgroup and agrees that there are one part of a system-wide approach. The expert advisory group felt that they should provide an assessment facility and facilitate appropriate admission, avoidance, and promote the ideal of community care provision. In relation to clinical age assessment units, the idea here was to follow the model established in Limerick, where a specific diagnostic unit for age-associated problems was established, resulting in shortening length of acute hospital stay. The idea is that a range of diagnostics targeted at common age-associated problems would be provided so that timely testing could take place in hospitals, as well as providing access to patients from the community with a view to admission avoidance. One of the key components of any such assessment unit is the provision of a syncope laboratory, as various forms of neurovascular instability are the principal reason for older people falling over, and falling over combined with dizzy turns, the single biggest reason for people presenting to hospital. It is bigger than chest pain. In the Limerick experience, the introduction of new technologies to allow for the non-invasive measurement of beat-to-beat blood pressure, developed first for the Cassiopeia mission to Mir in 1996, has transformed the manner in which falls and dizzy turns are investigated in our region. It provides a quick and non-invasive way to get a precise diagnosis and reduces the risk of unnecessary testing being carried out for, in inverted commas, funny turns. So continuous phasic hemodynamic measurements and the provision of tilt table testing, for example, is an excellent example of the type of technologies that can be readily deployed in a clinical age assessment unit. Excuse me. Tabulated here we have some data showing published data from various studies showing the prevalence of neurocardiogenic syncope, carotid sinus syndrome, orthostatic hypotension in various care settings, outpatient settings, electrophysiology departments, inpatient and outpatient settings. And at the bottom here, 1,412 successive cases of the clinical age assessment unit for people presenting with unexplained falls and dizzy turns, showing that various forms of neurovascular instability are virtually endemic in later life. We believe very strongly that this should be the first port of call in investigating such cases. Many of these cases spend inordinate lengths of time in hospital having unnecessary tests performed because of the lack of proper targeted investigation of these conditions. Here's a classic example of the type of trace that one sees in such patients. This is a patient who falls. This is their systolic blood pressure. The green line is heart rate, the bottom red line is diastolic blood pressure, and the patient is tilted upright. A physiological stressor not too dissimilar at all to standing, and you can see the very rapid drop in blood pressure, in this case sufficient to result in cerebral hypoperfusion and dizziness over just a matter of seconds, and this simply cannot be diagnosed with standard blood pressure measurement techniques. As a research aside, we often find that patients who present with this type of change and tilting have these type of bones. So they have a mechanism for falling, and when they do fall, they tend to be landing on these type of bones. And there's some interesting research studies taking place to look at a potential mechanistic link between these. In the top panel, we have somebody who's just got mild orthostatic hypotension with what look like robust bones. If you think back to the graduated cylinder cartoon that I showed you, you'll accept that it is necessary for some people, having been through an acute illness, to have a period of rehabilitation because they're operating close to their homeostatic reserve. The expert advisory group looked at the number of rehabilitation beds in residential care in the 4 parts of the country, and these are the figures that they have produced. So Dublin North East is certainly underrepresented, whereas the South and the West have higher numbers of beds. The total number of patients requiring rehabilitation as projected in Limerick would be as follows. At the present time, we have plotted here in purple the actual bed availability as opposed to the projected requirement in white. If we look at inpatient general care, we have in the region 40 dedicated 22 dedicated rehabilitation beds for elderly patients and none for young. We need 40 for elderly and 12 for young. We have 6 dedicated stroke rehabilitation beds for elderly and none for young, with a requirement for 12 elderly and 3 young. In relation to outpatient day unit provision, we have a provision for 16 but with a requirement for 50 and none for younger patients. I mention younger patients here because they're clearly, while the elderly are predominantly the principal users of rehabilitation facilities, there will be a small and very important cohort of younger patients who will need access to the full range of services set up for older people. And these are the conditions where rehabilitation provision is made in older people, positive for the tick, and X means not provided for. And as you can see again, younger patients with what might be described as age-associated requirements just are not getting any kind of provision at the present time. Now, this is a poor enough representation of the whole time equivalent therapy numbers in our region, and it can be seen that they're scattered through these artificial constructs of disabilities, elderly, mental health, childcare, and the working in effectively in silos, oftentimes not even interacting with each other. This leads to huge inefficiencies, but when one looks at the overall numbers of therapists, those that have been approved 168 and those that are in post 140, the numbers are actually quite large. So one can certainly start to think that if this model could be broken down and therapy resource targeted at need, as opposed to being divided up like this, then considerable efficiencies could result and very visible improvements for patients. The rehab centres will inevitably provide a focus for the provision of this, and we would suggest that single centres with would provide the nexus for rolling out rehabilitation services throughout the region, whether they be required in the rehab centre itself, in the community, in the acute hospital, but that they serve as the focal point for the provision of rehab services. And if there's a need for gym provision, it's provided in the rehab centre. If rehab needs can be provided in the home, then that's where they should be provided. If they're needed in ITU, that's where they're provided. Stroke is quite a good example. Here are the meta-analysis of the outcomes from the various stroke rehabilitation studies carried over many years, and overwhelming evidence now that the odds ratio for survival and disability favour the management of stroke cases in a rehab unit. We believe that the management of such complex cases needs to be structured and organised, ideally in a manner that can be replicated throughout the country. We know that if we take this approach, that even within Ireland, the type of data that have been generated internationally can be readily replicated. These are data published, I think, in the Irish Medical Journal a couple of years ago, comparing outcomes for stroke patients managed in a stroke unit versus a general rehabilitation unit, equal in every respect in relation to medical expertise and nursing expertise, but the outcomes are much different. Much shorter lengths of stay for patients in the stroke unit. The mortality at the time of discharge significantly lower in the stroke unit compared to the general rehabilitation unit, and this is seen even up to 6 months post-discharge. Much lower and significantly lower complication rates for patients managed in a stroke unit. So there is a compelling reason for us to get our rehabilitation care organised. Inevitably, of course, there is a requirement, and will always be a requirement, for patients to need access to residential continuing care, but only after their full rehabilitation potential has been realised and all therapeutic options exhausted. At that point, a structured system is then needed to determine whether patients need continuing care in a residential setting or comprehensive care packages that will support management in the community. And again, the expert advisory group recommended the development of continuing care guidelines and the establishment locally of placement panels to arbitrate on referrals to that panel using the continuing care guidelines with a view to determining the appropriateness, in particular, of the provision of residential continuing care. And these are the complex, these are not the complex, but these are the continuing care guidelines that outline the complex care needs of patients in our region in the Midwest, essentially describing five levels of care, which are described in great detail within the booklet. And this booklet serves, and the contents of it serve to direct the placement panel in assessing referrals and the appropriate pro forma. Ideally, any such system, particularly if it's going to be applied nationally, should be computerized. And for that reason, the Expert Advisory Group developed a UNAP, Unified Needs Assessment Program, and the Integrated Residential Assessment Program. It provides for a common assessment process that can be used by all healthcare professionals to ensure a coordinated approach to the care of the older person, and can be used across hospital and community services with a particular reference to determining need for long-term care. Individuals' needs are assessed through this common assessment process, and that process defines clearly what the individual's needs are, how best the need of the individual is to be met, facilitate the meeting of the individual's need, and then all individuals are assessed through the same process, and that process defines clearly the population needs, how best the need of the population is to be met, and facilitating the meeting of the population's needs. The UNAP, in effect, is an electronic system that is web-based and can be utilized throughout the country. It's got many different layouts and includes a range of assessment tools familiar to healthcare professionals that work with older people. So, what about the implementation of this type of approach? Well, the Expert Advisory Group was fearful of producing a report that would join the many other reports accumulated over the years and gathering dust. So, in the final stages of its work, the Expert Advisory Group gave consideration to an implementation strategy. It suggested that in relation to UNAP, for example, that there should be an agreed data set incorporated within it, that there should be a design and a testing of the software, which was been completed, and then a geocentric rollout, that it would be established in one part of the country where there was expertise and enthusiasm to establish it, and then thereafter for it to be rolled out geocentrically with the establishment of a network that would allow for the integration and storage of all data, and finally a phase where condition and process specific software evolution could take place. The net effect of all of this, of course, is that if the work that needs to be done in relation to managing age-associated disease will never go away. It will be done one way or the other. The more efficiently it's done, the less resource, the less cost associated with it. In the top part of this diagram, we have a system where you have clinical age assessment units, stroke units and functional vascular labs, continuing care guidelines, etc., with smaller blocks of resource needed for acute rehabilitation and continuing care. Without these specialist facilities, your requirement for acute care will rise, your rehabilitation requirements will rise, and you will have a burgeoning continuing care requirement. So it's a matter of taking your pick. So, the message from all of this is that comprehensive and responsive diagnostic and assessment facilities provide major advances for acute hospitals. Efficient resource utilization will result both in the acute and rehabilitation and continuing care settings. It will facilitate the prompt application of the evidence base so that patients see the early benefit of proper research and academic output. It supports a culture of inquiry and ultimately and most importantly results in a better patient journey.